Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about Ingrezza, or valbenazine. This is a drug approved just in April of 2017 for treatment of tardive dyskinesia. It's first drug licensed for that purpose. Now, the tardive dyskinesia probably affects about 500,000 individuals here in the United States. And the tardive dyskinesia, for the most part, is a complication of therapy for some other condition. Typically, it's a complication of antipsychotic therapy, drugs that are used to treat schizophrenia and drugs that are used to treat the mania of bipolar disorder, and unfortunately an increasingly long list of off-label indications. The tardive dyskinesia itself is a neurologic disorder. It's stereotyped repetitive involuntary movements affecting the jaw and the lips and the tongue and the face and the mouth, and sometimes the upper extremity, lower extremity, or the torso. It's grimacing or sticking out the tongue repetitively or smacking the lips. Sometimes the person who suffers the condition is totally unaware that they're affected by it. Sometimes it's even more of a problem for the caretaker. While most of the time it's associated with an antipsychotic, sometimes it's a side effect of drugs used for gastrointestinal disorders, for vomiting, or to increase the motility of the intestines, drugs like Reglan. But most of the time it's due to an antipsychotic. So the original antipsychotics were drugs like Haldol and Stelazine and Serentil and Prolixin and Navane and Trilafon. And then we got a little more sophisticated, and the drug industry brought out drugs that were supposedly safer, drugs like Abilify and Risperdal and Zyprexa and Seroquel and Geodon and Clozaril and Vraylar, Latuda, Zafras. Those drugs supposedly, the atypical antipsychotics, had a lower incidence of tardive dyskinesia, but actually the longer they've been out, the more that it seems that they probably aren't all that much safer than the original drugs. If you take an antipsychotic, it's estimated that after 1 year, about 5% of the people taking it are going to have tardive dyskinesia. And at 5 years, that number increases to about 25%. And if we look at 10 years, the number is about 50%, and it increases to over 70% in people who have been taking the drug for 25 years. And worse, if you discontinue the drug, symptoms go away only about 10 to 15% of the individuals. Now, the antipsychotics, atypical or typical, are used principally to treat schizophrenia and the mania of bipolar disorder. But the drugs are being increasingly used for a lot of off-label indications: major depressive disorder, or insomnia, or anxiety, or post-traumatic stress disorder, for certain mood disorders and autism, difficult personalities, people with aggression or agitation, people who have obsessive compulsive disorder, or people who have restlessness and dementia. Well, if you take the drug, the recommended dose is 40 milligrams once a day for a week, then increase it to 80 milligrams once a day. Now, if you have moderate to severe liver disorder, you should only take a maximum of 40 milligrams a day. And if you have some abnormality on your electrocardiogram, something we call a long QT interval, you got to be careful, because its use theoretically could lead to some severe arrhythmias. In the study that was used to evaluate the drug and to bring it to market, they evaluated people who had moderate to maybe severe tardive dyskinesia. They studied them, double-blind study, for only 6 weeks. And then after the 6 weeks, when they received either the 40 milligram dose, the 80 milligram dose, or placebo, they kept them on until 48 weeks, unless they were taking placebo, in which case they were switched to the 40 milligram or 80 milligram dose. Now, the study ended at 48 weeks, and the people were reevaluated off therapy at 52 weeks at the end of a year. So, did they have a big study? No, actually, there were only a little more than 200 people involved in the original study for the 6 weeks, and the follow-up study really only evaluated about 60 people in the 40 milligram, 60 milligram, or 60 people in the 80 milligram. And to do all of this, the studies were done in 59 centers here in the United States, 2 in Canada, and 2 in Puerto Rico. So now we've followed 120 some odd patients for about a year, and it takes us 63 centers. That means already that there might be some difficulty with standardization, but let's forget about that. So the studies were done in people who average age of about 56, ranged anywhere from 26 to 84 years of age. Half of them were men, half of them were women. 85% were on antipsychotics when they entered the study. About 15% had already discontinued the antipsychotics. They looked at change in something called the Abnormal Involuntary Movement Scale, or AIMS. It's a 12-point scale. They only used the first 7 items, which is standard. Each item was rated as 0 to 4, so you could theoretically have a score of 0 to 28. You would get a score of 0 if you didn't have tardive dyskinesia in that area that they were evaluating, a 1 if you had low amplitude tardive dyskinesia that was present sometime but not during most of the exam. A 2 was the rating that you had if you had low amplitude present during most of the exam. 3 if you had moderate amplitude condition during most of the exam, and 4 maximum amplitude. Now what does all of that mean? They had to rate individual areas because they wanted to get a view of how it affected, for instance, the muscles of facial expression. So they were rated as far as movement of the forehead and the eyebrows, frowning and blinking and grimacing. And then they rated the area involving the lips and the perioral area, puckering and pouting and smacking the lips together. And then they rated the area involving the jaw, where the people biting or chewing or have mouth openings and closings or lateral movement or clenching disorders. Or did the people have tongue abnormalities? Did they show darting of the tongue in and out of the mouth? Or they looked at the upper extremity, the hand, the wrists, the fingers, and was there abnormal movement there? And then they evaluated the leg, and then they evaluated the neck and the shoulders. And they put all of that together to get a score. So the average score on entry was about 10. And the good news is that at the 40 milligram dose at 6 weeks, the score was down by about 2 points. 80 milligram dose down by about 3 points compared to the placebo, down only 1/10 of a point. The bad news is that after therapy, if we look at the 40 milligram dose, the score was still about 8. If we look at the 80 milligram dose, the score was still about 7. Placebo was about the same as it was when they entered. Now, if we look at the no change or worse in the 6 weeks of the study, 35% of the patients had no change or they were worse if they were taking the 40 milligrams. And if we look at the people who were taking the 80 milligrams, 25% of the people were not improved or they were worse, 50% in the placebo group. If we look at major improvement, almost complete resolution, an improvement of 7 to 9 points in the 40 milligram dose, just 6%. Almost complete improvement in the 80 milligram dose, about 20%. 4% in the placebo who didn't have any kind of therapy. If we look at overall improvement of, let's say, more than 50%, in the 40 milligram dose it was about 25%, the 80 milligram dose about 40%, about 10% in the placebo dose. And actually, the 40 milligram dose was not statistically significantly different from the placebo dose. And if we look at the complete resolution, it seems like there isn't much difference with or without the drug. But it did seem that the patients who did improve seemed to maintain the benefit between week 6 and week 48. Then they were stopped, the therapy was stopped, and they were reevaluated after another 4 weeks passed. And the symptoms were all back. So it's not a cure, it's just a treatment. Well, the study was done, with few exceptions, by people who were either being paid by the company or employed by the company or had some financial interest in the company, and the company designed the study, collected the data, conducted the study, and wrote and edited the study. So everything in the world going for it, and it comes up with what I think we could say are sort of mediocre results. If we look at this rating score, it's extremely reliable, but only with experienced observers. But the company did videotape the examinations and send them to central observers who were theoretically unbiased. But a significant improvement is generally about a 30 to a 50% reduction in the score. So if we look at the people receiving the 40 milligram dose, it was a 2-point difference. That's not a 30 to a 50% improvement. If we look at the people receiving the 80 milligram dose, it was a smidgen. It was right at that 30% line. So we have improvement, but we don't have a phenomenal degree of success. And it all depends on the rating. So you could have a 1 in 4 of those different areas, or you could have a 4 in just one area. So you could have major abnormalities, say, of your mouth and no other abnormality, or you could have a little abnormality in your mouth, a little abnormality in your forehead, around your eyes, a little abnormality in your hand. So it all depends exactly how you get to that score. And a little minor twitch in a high-functioning individual of the eye or the mouth might be a heck of a lot more important than a major abnormality in, let's say, an extremity, if the person is going to work. Well, there are some warnings and precautions if you take the drug. There's the potential for somnolence, tiredness. There's the QT, the electrocardiographic abnormality, and it can interfere with the metabolism of some drugs, and some drugs can interfere with the metabolism of this. And the other drugs in the family seem to have a boxed warning for increasing depression or violent behavior, suicidal ideation, but so far the number of patients who have been studied with Ingrezza is too small to indicate whether that's going to be a problem. The drug works on the little area within the cell, within the nerve cell, in the central nervous system, that sort of collects the dopamine. It's known as a vesicular monoamine transporter 2 inhibitor, a VMAT2 inhibitor. And that might be the way it works. That's the suggested mechanism, but is that really the way it works? We don't know. It might be working on the GABA, it might be working on the neurodegeneration, it might be working on a variety of other factors. But we do know that the drug, when you take it, isn't an active drug. The drug is a prodrug. It has some valine attached to it, so it has to split that off. And then the drug is altered into the metabolite. And the drug and its metabolite seem to have the function. So once you take the drug, it enters the bloodstream in maximum concentration in about half an hour to an hour. The half-life of the drug and its metabolite in the system is somewhere around 15 to 20 hours, so you only have to take it once a day. The bioavailability is about 50% of what you take in. It gets into your system, and it's excreted principally in the urine, some in the feces. It's probably not very safe if you happen to be pregnant. It's not recommended that you take it. Certainly in laboratory animals can cause fetal harm. It can disrupt the estrous cycle, result in a lack of fertility, change in fertility. It changes the hormone known as prolactin, and prolactin, when it's increased, tends to decrease ovarian function, not recommended in women who are breastfeeding. If you have mild to moderate liver disease, then Ingrezza concentration is going to increase by about 2-fold, increase by 3 to 4-fold if you have severe liver problems, so obviously shouldn't be taken. If you have mild to moderate kidney impairment, well, it's okay to take the drug, but not if you have severe kidney impairment. Shouldn't take it if you happen to be on an MAO inhibitor. Can lead to the serotonin syndrome. Should stop the MAO inhibitor about 2 weeks before you take the Ingrezza. And if you take an inducer of certain drug metabolizing enzymes, that's going to lead to a marked reduction in the concentration of the Ingrezza in your system. So you have to be careful, because the Ingrezza might not work nearly as well as you expect if you happen to be taking Tegretol or rifampin or Dilantin. And by the same token, if you inhibit some of the other enzymes that metabolize drugs, well, the concentration might increase substantially if you take ketoconazole or clarithromycin, or if you're taking Paxil or Prozac or quinidine. Drug dose has to be reduced. Well, some of the other side effects, other than the somnolence, fatigue, and sedation, potential difficulty driving a car because of the somnolence and balance disorders and some restlessness and some vomiting in some people, may increase the blood sugar, increase the weight, cause some anxiety and drooling and insomnia, causes that increase in the prolactin that I mentioned. Some people develop abnormal liver function, or may develop a hypersensitivity reaction. During the study, the extended period of the study for the 42 weeks, about 70% of the people had at least one side effect. 15% of the time it was rated as a serious side effect, and 16% of the people who were taking the drug discontinued the drug because of a side effect. The federal government, the FDA, has an adverse event reporting system, and this adverse event reporting system is voluntary, so doctors who have patients who complain of problems report to the FDA. It's voluntary completely, so the number of cases really is a low ball. It's estimated that fewer than 1 in 10 side effects are reported, but even so, in 2017, there were already more than 800 side effects reported to the FDA. The number increased to over 4,000 in 2018. The number of serious side effects, including death, was about 650, and the number of deaths associated with the drug, not necessarily caused by the drug. There's no cause and effect. We just know that they're reported in people who were taking the drug, was still the death 116. And that's thought to be just the tip of the iceberg. So if you want to get a prescription for the drug, because of the cost and a variety of other factors, in certain areas, let's take Minnesota as an example. Well, if the Department of Human Services in the state of Minnesota is going to authorize the use of the drug, you have to have, of course, documented tardive dyskinesia. You have to have been on drugs that caused the condition. The condition had to be present for at least a month or two, and your doctor had to prescribe it in consultation with a neurologist or a psychiatrist. You had to have a documentation of functional impairment. Remember I said that you can have the condition and you might be totally unaware that you have it. If you were taking an antipsychotic, maybe switch to a different drug or use the lowest possible dose unless there's a medical reason why you can't do that. And the baseline score on the AIMS had to be at least 10, and you have to have tried another drug called Austedo. And why? Well, because the drug is really expensive. Actually, the Institute for Clinical and Economic Review, that's a nonprofit group that rates the cost effectiveness of various medicines. And it's thought originally that the cost effectiveness for one quality adjusted life year of improvement should be about $50,000. Then they slowly raised it to $100,000. Now it's $150,000, but Ingrezza is more expensive than even that. The cost per year could be as high, to increase the one adjusted quality adjusted life year, the cost could be $750,000. So according to the Institute for Clinical and Economic Review, the price would have to fall by about 85 to 90% for it to be acceptable. Now, the company wanted to gain authorization by the FDA for Ingrezza as a treatment for Tourette syndrome. Unfortunately, the studies failed, even though the company designed them. Didn't top the placebo, but the company says they're going to try again. They're going to try again because they anticipate that this could be a blockbuster drug that could bring in about $2 billion or $2.5 billion in sales. And much of the drug benefit would come from Medicare or Medicaid. Well, originally, they thought that the drug should probably market for somewhere between $60,000 or $20,000 to $60,000 a year. Well, that's an awful lot of money. And what did they finally do? Well, they finally, in order to work up some enthusiasm for the drug, they have an infomercial that's running. And this is advertising a website called talkabouttd.com. And if you watch that website, you go to the website and watch, it's telling you all about the benefits of having this condition recognized and appropriately treated? Well, the benefit is to whom? What is the price of the drug? The price of this drug is $263 if you pay cash for it, for a day. One day, $263. If you happen to have a coupon from GoodRx, it's about $200 a day. So we're talking about a drug that costs somewhere around $80,000 a year. $80,000 a year. And guess what? Since the time it was introduced, in mid-2017, the price has already gone up. Well, remember, the drug is used to treat a complication of taking another drug, a drug typically an antipsychotic. And it might be necessary, but there's a tendency now in people who have schizophrenia to use lower doses or try even to treat some of the patients without the drug. And now, although it's being pushed for the mania of bipolar disorder, there are other drugs that appear to be better for the mania. And then there's the indication creep. So people are using the antipsychotics that are potentially dangerous for a variety of indications for which the FDA has not granted approval. So the drugs are being abused, unfortunately, and the complications seem to be relatively frequent. And tardive dyskinesia is just one of the complications of taking these drugs. So if you do develop tardive dyskinesia, is Ingrezza a gangbuster treatment? No. It's okay, but the cost, that's absolutely ridiculous. Anyway, thanks for watching. I'm Dr. Ken Landau.